Well, thanks for inviting me tonight, and so thanks to Nuria in particular. And I'd also like to join Lachlan in paying respect to the traditional owners of the land, past and present. The title I've come up with for the talk today, Walking the Line, Borderline States in Context. Let me just point to a few things in the title. It's useful to think of borderline states. I'll be trying to give what I'd consider a whole person perspective today, but often clinically we are seeing people in crisis a lot of the time, often in their, you might say, their worst states, their more socially difficult states, if you like, often with a quite projective element to the presentation, often with quite a lot of anger. So it can be difficult clinically. We do have a sense that we're walking the line sometimes, and we'll often, I think, have the experience of feeling we're being pushed or pulled, that our limits are being tested, as it were. I mention that because I think there has been a change. There have been a number of treatments, a lot of RCTs that tell us that conditions like borderline personality disorder can be helped, and that's good news. The Westmead program to which I belong was one of the first to publish in this area. However, I just mentioned there's another side to this kind of outcome study. Back in the late 1980s, when I was starting to train in psychiatry, expectations were quite low. People said personality disorder wasn't very treatable, really. So you didn't go in with great expectations, and if you could make a connection and start a conversation, you felt like you were ahead of the game, I think. When you have a lot of research that tells you you should be doing well with these people, well, it raises expectations. It raises the expectations of the patients as well, I think. And we should be a little bit cautious about that, because they remain a difficult group to treat. Certainly the more severe borderline patients or personality disordered patients are difficult to treat. You're not always going to be successful in your treatment. And I think managing one's expectations is part of trying to do a little rather than a lot necessarily. And I think that's a better attitude to have. And just a word on context as well. The context, even though we're confronted with a state, you might say, the context is always the whole person on the one hand. It's also the interpersonal environment, the network, the cultural network that the person comes from. So it's always larger than what we see at first glance, you might say. On the template that I use from the university for these talks, this was the learning objectives one. I'm not very big on learning objectives. I guess I'd hope I might get people to think about some things. So I call it themes for reflection. We're going to hear from Dominica a little about the importance of emotion regulation and, approaches like DBT. That's quite a central concept there. I guess the point I'd make there, though, it's a kind of an entry point, I think, one that you can often see common ground with patients, that this is something that you both agree it would be good to work on. But there's a question about what's the underlying problem as well, and whether one sees the problem just as emotion dysregulation. In our work, we would tend to see that a lot of people with personality disorder have a core dysphoria, a kind of distressing, uncomfortable mood state that they often can't really describe a time in their life before that. So that's why we would call it a core dysphoria. And we would see that as a central construct. I don't want to pick on Dominica, but I did notice in your talk, Dominica, that you used the term biosocial rather than, we'd often talk about biopsychosocial. And I think it's important to remind ourselves that when we're talking about psychological intervention, psychology, the psyche, refers to a mind, to a soul, to a spirit, to a whole person, in fact, to a whole person's experience. And, we may do things that are helpful, but it's always going to be partial, it's always going to be a little incomplete. I'd also make the contrast between the medical model, which we use it for pragmatic reasons. It's a kind of way of systematising, we can share an understanding, and people sometimes will identify with diagnoses. It can be helpful. But it sometimes can get us away from what things mean to people. And as psychologists or working in this psychotherapeutic field, we're always dealing with meaning. And I'd suggest that meaning is also a whole person concept. One that is based in feeling, which is an element of all states, all mental states that we deal with or we experience. One that involves relationship, and one that's developed through a conversation. It can be shaped through a conversation. So people change through the kind of exchanges that occur when we talk to each other. Talking is often undervalued, I think, but our lives are shaped by the exchanges we have with the people around us as we grow. And I'm going to just refer to this concept of worldview. People come from very different backgrounds. If you come from an environment which is inherently traumatic, where you're not getting nurtured, then the core of your personality will be forming around a different set of feelings to those that have a better experience early in life. The worldview that we develop under those circumstances, we take to be the facts of life. This is the way people are. So as you emerge into life, children don't know anything different, do they? And so I think when you think about personality disorder, we're often dealing with a disturbed worldview, but one that is, although it's felt as a fact, is actually based on a set of feelings in experience. And it is potentially open to change, I think. It's not easy to change, but it can be changed. It's a concept that I think is also somewhat relevant to the intercultural conversations that we have, that people here in Staats will be very familiar with, I think, where people are coming from a very different background, often a very traumatic situation, and where we can't pretend really to see their worldview necessarily. Actually beginning to see it, beginning to understand, actually it takes quite a lot of communication, I think, and is an important part of the work we do. They say that the personal is the political. I found this a pretty evocative photo of what we might call boat people. I use that term because it's become such a political hot potato in Australia, and it really has become associated with a group that are on the outer, that are not really accepted. Many people here would find that outrageous, but it is the situation that we're all part of in some way. There's a story here which is personal, but my father very much identified himself as a boat person. Now, this wasn't literally true, but the reason he identified in that way is that he came really escaping the Nazi threat as World War II was breaking out. So escaping from Europe, a member of a Jewish family, on a boat. And the boat got commandeered for the armed forces during the trip when the war broke out. So his trip was interrupted, in his case only by about 3 weeks. He got on another boat, came to Australia, and finished his schooling in Australia and had a successful career. Now, So that's a positive experience, but he could really understand how close he was to being in a much worse situation. So all of these things I think will be familiar to you. In refugees we see people who are dislocated, often whose major attachments have been disrupted, who've suffered terrible loss, but worse still, that they're often in dehumanising situations. And the authority figures, the people that have power, are often also a source of fear. So this is a situation where we get mixed up, where we might lose the sense of security certainly, but also a sense of who we are and what counts, what values matter. It's certainly difficult to feel any sense of belonging. And I think in that kind of description you might see a comparison to the notion of disorganised attachment, which is a central factor, I think, in the development of conditions such as borderline personality disorder. I keep qualifying it such as borderline personality disorder because there's a trend, I think, diagnostically towards recognising that it's the more severe personality disorders that we're most concerned about clinically. They probably vary along dimensions in terms of the symptomatic pattern, and so they're not all classic borderlines that would have that kind of background, but that's certainly one of the kind of presentations that would be associated with it. This slide may also be familiar to you, quoting the work of Sillev and Mears. I just draw your attention to the title of that paper, The Mental Health of Refugees and People Who Seek Asylum. So the point I'd make here is that the word people, person, self, these kind of words we might take for granted, but they're not strictly speaking objective states or something we can measure. And again, I think in your situation at starts, you should be kind of familiar with that people can be treated as non-people, if you like. Part of the point of the article, I think, is that when we do treat people humanely, it actually is possible to help them generally, but you need to have a system that is supporting that. So again, there's parallels with the disorganised attachment. If you compare justice with the kind of inequality, really, that is inherent in having a bad start in life, and that is an inequality that's difficult to redress, then perhaps it helps us to empathise a little with people's situation. Of course, when you look at world history, it's a litany of conflict and genocide and terrible things happening. So there's a lot not to be proud of in humanity as well, of course. Man's humanity to man hasn't changed all that much, maybe. It certainly still happens. It's a strength in health practices that we endeavour not to pass moral judgment. And one of the ways that we do that is to try and look objectively at situations. And that can be quite successful in many ways. But there's a bit of a risk of turning a blind eye to what things mean to people. And concepts like trauma are meaningful. There's a trend within classification systems towards greater recognition of trauma. So if you look at the DSM over the last 40 years, as you would know, PTSD was only introduced around 1980. So it was the first time trauma was officially part of a classification system. There's now a whole chapter with about a dozen disorders, and there's several other chapters in which trauma and stress are recognised as significant causal factors. So I think there's a growing awareness of trauma, and I think that's reason to be hopeful about people recognising this whole person aspect of what things actually mean to people as being something that we need to work with. We all have a tendency to denial. So, I mean, speaking for myself, I'll have times when I want to switch off the TV because it's too much. You know, I'm sure most people would feel like that. You can feel like that clinically as well. And, you know, one of the reasons I want you to think about adjusting your expectations and not expecting too much of yourselves, giving yourself credit for what you are doing and what you're trying to do, getting some supervision and peer support, is that, you know, we don't want you to burn out, but there's a danger of that happening. So, you know, the natural tendency to denial and avoidance can sometimes lead us away from providing the treatment that we might need to provide, actually. Just bringing home the fact that, you know, DSM still will tend to emphasise extreme events, whether they're developmental or occur in adult life, as the basis for a diagnosis of PTSD or complex PTSD. But relational trauma are much more common than that. So I like this quote from Russell Mears, my colleague from Westmead. I'll just read it. So, relational traumata are of immense importance. They are an aspect not only of every clinical encounter, but also of daily life. Most people will have had an experience, a moment of misery, perhaps a wave of desolation, or merely a flicker of such a state, triggered by something said or remembered. The moment usually passes. In some people, however, it does not. It's magnified and long-lasting, upsetting personal relations and overthrowing the ordinary feeling of the flow of existence. So, I mean, in your day-to-day life, you'll probably be able to notice something like that. Sometimes something happens and you won't want to talk to someone for the next week. You know, sometimes it's more severe that relations get broken off completely. But they have significance for people. And of course, when the fabric of the relationships of primary significance, of the primary familial relationships, is full of fear and full of ambivalent feelings, then you can see it's going to have a whole effect on the body. It's going to affect your brain, it's going to affect your feelings, and it's going to lead to chronic disturbances that are difficult to address. Just on the theme of things having meaning and not really being reducible to a diagnosis. So physical abuse, when that occurs, will always involve an element of not only helplessness but humiliation. Sexual abuse involves those things, but also it's an assault on the tender emotions. We can't trust our feelings with people when we've had that kind of experience. It's difficult to recover from. They all involve an attack on humanity, but that's an attack on how our nervous system works, how our bodies work as well. In the abstract that I'd written for this, I mentioned a couple of books that I'll refer to briefly. Paul Kamel is a psychiatrist working out of Victoria in South Australia. He highlights that the borderline concept is a limit concept. And originally it was on the border between psychosis and neurosis. So even though it's often talked about in other ways, that's where it came from. And you can still see that in the presentations we work with. I think he's also pointing in this quote, which I won't read in full, to a more complex situation, which you may or may not agree with, but he refers to the limits of our permissiveness, the after effects of our openness to explicitness, sexual, violent and graphic, and the collision of our high ambitions for individualism individual rights and responsibilities with frank problems of neglect, omission and maltreatment. So these are all things we'd in some ways rather not know about, so we often disavow them. But they're real enough. And from the individual perspective, from the subjective perspective, this is the terrain of the brutal, the savage, the rough, the bad and inhumane ways we treat each other, including our children. And we sometimes do it pragmatically through these methods of clinical sterilisation, clinicalisation, medicalisation or technologicalisation, the words he uses, but it's getting away from the meaning that is generated in interactions between people when we think in that way of disorders or even feelings as things to be manipulated in some way. So Paul uses this term hermeneutic ontology, which is a grand-sounding philosophical kind of concept, I guess. But, what he's referring to, I think, is that our lives unfold in interaction with each other, in the conversations we have with each other, and that these things are real and embodied, and they affect our whole system. So, again, I think he's referring to a kind of interpersonal and whole person perspective on the matter, which I find useful. And in conversational model, we would very much take that perspective that I can only find myself in and between my fellows in a conversation, is a quote from Robert Hobson. You're going to hear about a patient called Lila from Dominica. And this put me in mind of this other Lila that I read about. The point that's being made by Jerome Kagan here is that we tend in a medical framework to understand feeling as a thing, which is a mistake. Feelings are part of an emotional process that unfolds in time, certainly part of our experience, and they're part of every mental state, so they're a pretty central part of experience. But he says that the conceptualization of emotion by Western commentators has been a replacement of the implications of an agent's feeling for the integrity of and their relation to others in the community as the criterion for classifying emotions, with each individual's sensory pleasures and biological fitness. So, I think when you see a culture where people take uppers and downers and are seeking a quick fix in terms of changing their emotional state, it's a kind of limited view, it's a one-person view, it's not an interpersonal view, and it's not a particularly meaningful view, it's a rather empty view. And of course, borderline patients suffer from a sense of emptiness. So even though many of them are quite drug-seeking and will often be pushing clinicians to prescribe, we tend to find it doesn't help all that much, in fact. And certainly that's one of the findings from the NHMRC guidelines that I was a part of. Look, again, I won't read this one in its entirety, but this is a quote from Emmanuel Levinas. And one of the things that we're aware of in terms of psychodynamic theory is that the unconscious abhors a vacuum, as it were. Levinas is talking, he was in a concentration camp in the Second World War, part of the Holocaust. So he's coming from that perspective, where he was in a dehumanising environment, where there was a situation of real horror, I think it would be fair to say. But this manifests as a sense of a presence, if you like, within the experience. So there's this rather vague term, there's something there that's really uncomfortable, but it's not a nothing, and yet it's arising out of this sense of dehumanisation. In our own work, looking at borderline patients, we did a study where we looked at the number of patients that report hallucinatory phenomena. And that number's quite big. I think it's very big in people that also have traumatic experience, PTSD, particularly those that dissociate. So it's probably pretty familiar to the clinicians here. It takes a form. So the kind of hallucinations that are more typical in this group often would be a whole person. It often had some significance in terms of the person's background. Might be someone from their background, or it might be symbolic of someone in their background. So it wasn't quite the same as the more typical situation in a schizophrenic presentation, where it's often very hard to make any psychological sense of the hallucination. And these were people that could still be worked with. Often they would keep it a secret that they had these experiences because they knew they might get hospitalised or put on medications that they didn't necessarily want to take. This poem, I won't read it all again, but by Edgar Allan Poe, himself a man who had problems with addiction, probably personality disorder, but famous in the world of literature for his horror stories, really. I think this is quite an evocative poem about what it is to be different. And again, in a way similar to Levinas, it starts with from childhood's hour, I have not been as others were, I have not seen as others saw, I could not bring my passions from a common spring. But it ends with the demon in view. So the what is absent, what is missing in the person's life actually takes on a form in this way, you might say. And patients in this group are often haunted, not only by the trauma they have suffered, but also by the things they've done themselves, as in this quote from Zanarini and Frankenberg. A house haunted by the memories of what others have done to them, but also what they in turn have done to themselves and others. So I think there was mention by Lachlan of, sometimes having to help people that have perpetrated abuse as well as those that have suffered it. If you're looking at a military population, it's a bad prognostic sign when people have killed people. They actually do worse symptomatically. So, there's always two sides in traumatic situations, and as clinicians we often have to treat both of those sides, and they are often occurring in the same person. There's another study that we did on harm avoidance. So harm avoidance is one of Cloninger's temperamental constructs. There's harm avoidance, novelty seeking and reward dependence, all of which have somewhat different neurochemical transmitters and different parts of the brain involved in them. Now, it was predicted originally that borderline patients would score low on harm avoidance. After all, they harm themselves a fair bit, the reasoning went. Actually, we found in our group that they score very high, so the normative readings are between about 15 and 18 in all of these different subgroups. And you can see they're kind of off the page a bit in terms of having high harm avoidance scores. This actually suggests that there's an effort at avoiding harm, and I think it probably needs to be understood when you see people still actually harming themselves, that the internal pain that's being experienced is such that it's a relief to hurt. The pain of the cutting or whatever it might be is less than the emotional pain that they had been in. I think it's a useful perspective to have, and there's evidence that bears that out. It's really just another representation of that. We did find that over 12 months these scores actually improved a bit, so that's interesting as well. Technically temperament's not supposed to change that much, and yet there's a suggestion that it does. Now, if you read Cloninger, his theory would have it that things that are emotionally driven are temperamental. The point I'd make, though, and I think I might have highlighted already, is that we're not born with all of these emotional states. We're born with potentials for emotional experience, but they unfold in time. And a lot of emotional experience and the patterns of it are learned, I think. And there's potentially, I think, can be modified as well. So I think temperament may be a bit less of a fixed construct than it's been portrayed. At the same time, we should recognise that generally these things are contributed to by both nature and nurture. So there are temperamental differences, and I wouldn't want to deny that. I've highlighted already that we would see core dysphoria, and others have also really seen the borderline construct in this way. So Zanarini, Russell Mears, Drew Weston all talk in this way about the affective core. And, you know, if you think developmentally, then we would develop an affective core after 2 or 3 months of life. So it's really very deeply embedded in who we sense ourselves to be. And if you're dealing with something that's really quite difficult to contain, then perhaps it's not surprising that you have worse than death experiences. I think we'll hear something of that sort from Dominica's patient, but also from that paper that of Silov and Mears that I referred to. So with the refugee population, I think it would be quite common for people to say, you know, it would be better to be dead than to be keeping going under the circumstances I'm living in. And I think that kind of thing is relevant to people with personality disorder sometimes. One of the important things, you know, we tend to live in an age where people want to ration treatment, to restrict it to 10 sessions or whatever. You know, I think it will vary. Some people can be helped with brief interventions, and that's a good thing. But some people do require much longer periods of time to be helped. And I think we should have a system that allows that to happen. So there's a couple of messages. One is that sometimes if we get too medicalised, we can overlook trauma and what things actually mean. And that can be an elephant in the room. But also that if we think in terms of a developing person, of a developing self, well, the needs of that person, the needs to talk, to connect, to be in relationship, are part of what will make a difference eventually for them. So the self can be overlooked as well, can be another elephant in the room. I'm probably running out of time. I can see I am, so I'll try and be quick if that's all right. Maybe another 5 minutes. Is that going to be okay? The second book that I'd mentioned in the abstract was this one by Potter, who's a philosopher, one who's worked clinically as well. And she talks quite a lot about the anger of the borderline patient. And you know, that would be familiar. Often we have to kind of wait till people calm down. We help with the emotion regulation. But I guess there's a danger that we then overlook the anger, would be the point that I'd make. She talks about giving uptake, is a phrase she likes to use. By that she means taking seriously that there are reasons for the person to be angry. And often they're developmental, often they might be out of proportion to the immediate situation. But ultimately, you need to spend the time with the person to hear that and respond to it, and to validate, often, that experience. So it's not just a matter for waiting for people to calm down. So we've talked about complex post-traumatic stress disorder. I'll just make the point in relation to this that whilst, yes, we do need to recognise these terrible situations of torture, slavery, genocide, etc., a lot of trauma is more in the category of the relational trauma that I referred to earlier. and yet they don't really get a Guernsey in terms of the classification systems. And I think that's a deficit. I think anyone working clinically would recognise that deficit, I would hope. When you think developmentally of the impact which you will see in the still face experiment, just the momentary lapse of responsiveness can hit the infant like a brick sometimes. So you can see how sensitively attuned people are, and how much people are having to adapt when they're in circumstances where they're not getting that kind of responsiveness. So many of the responses we see and make diagnoses and call disorders can be seen as being normative from a certain perspective. It's good that we're more optimistic about treatment, but we should be a little bit circumspect and not expect too much. I get concerned. I mean, you might be aware in the DSM-5 that personality disorder is no longer on a separate axis, so we don't have axis 2 disorders anymore. Some people say that will raise the status of personality disorder as being as important a disorder as other things. It also might have the effect that people tend to make other diagnoses and not think about personality, so I have some concerns about that development. You'll also hear that a lot of people are saying that structured therapies are the way to go. They may be, but from a conversational model perspective, I'd say that you can do a lot of structuring through a conversation, and being reliably present, being active in that relational role, and seeing responsiveness, not just listening, as part of the role, will go a long way, I think, to providing structure. So I don't think there's anything magical about structure, and sometimes it gets used to dismiss treatments that are actually more focused on meaning and the specific needs of individuals over a longer period of time, and that would be a shame if that became normal practice. We shouldn't forget about other things that are helpful as well, and it's not only talk that is helpful. When I say beware of the heroic treatment, I think where people do get into trouble is where they feel it's all up to me and I'm not part of a system, not part of a team. I think that gets you into dangerous territory, and I would caution against that. We're trying to develop a stepped care program, and I'll finish on this note. Joel Paris has run one of the more successful stepped care programs in Montreal. He borrows from other approaches, notably DBT and the concept of radical acceptance as a prelude to getting a life, as he puts it. But it does provide a range of options for people, from a short intervention up to about 2 years of intervention. And people can re-enter the program for that matter. So I think it's a program that probably does go quite a way to addressing needs. It's always a problem in the public sector as to how to meet the need. So I think the stepped care has something to offer. Humanity works. The trick is to be in that number. And that's the difficulty many people face. All of this is everyone's business. Some of you will be suffering vicarious trauma in your work. You need to look after yourself, supervision, peer review, not being isolated. On many readings, a large proportion, maybe up to 90% of the people we see, have a significant history of trauma. I'll finish there. Thank you.